Hello, let's learn about urinary tract infections and acute febrile illness. Let us understand what is syndromic approach for testing. A symptom is a feature apparent to patient like a sore throat. A sign is a measurable indication of a disease, like a temperature of like 100 Fahrenheit. A syndrome is a set of signs and symptoms that characteristically occur together. Syndromic approach allows clinicians to choose the recommended test based on clinical presentation, epidemiology, and allows optimum resource utilization. Repeat again, symptoms plus signs contribute to syndrome. How to do diagnosis stewardship in acute febrile? What is fever? Normal the temperature is about 36.1 to 37.2 degrees Celsius, while mild fever is about 38 to 39 degrees Celsius, while moderate fever is 39.1 to 40 Celsius. High grade fever is more than 39.4. Hyperparaxia is more than 41.1 Celsius. Repeated oral temperatures in fever is more than 37.2. Rectal temperature is more than 37.5. An increase in the temperature of the baseline temperature is called as fever. Any increase above normal body temperature is not fever. Wait and watch till there is a temperature about 100 Fahrenheit or 30 degrees Celsius. You can refer to clinical infectious diseases article for the same. What is the diagnostic approach for febrile illness? Acute febrile illness less than 3 weeks, fever up to 3 days without red flag signs, no need to investigate. Fever with localized signs, investigate according to clinical clues. Fever without localized signs, never onset. Fever with organ disinfection, have a routine workup. Febrile illness more than 3 weeks, follow the Pirates of Unknown Origin guidelines and have an advanced workup. Here we see an algorithm for acute localized infections, and then we have no localized features and unrelated to sepsis too. So based on this algorithm, we can have an algorithm. We can have a workup for viral, bacterial, and parasitic infections. What is sepsis? Sepsis is the third international consensus definition task force advocated a new definition of sepsis and septic shock in 2015. The previous version were for sepsis 1 and 2, while the present version was sepsis 3. A complex syndrome of physiological and pathological abnormalities resulting from infections contribute to sepsis. It's a life-threatening organ disinfection due to dysregulated immune response. Sequential sepsis-related organ failure assessment called as SOFA score, a score of 2 points or more contributes to sepsis. Septic shock is a sudden onset of sepsis with profound circulatory, cellular, and metabolic abnormalities and associated with a greater risk of mortality with diagnosed sepsis. Here we find this as a SOFA score. A score of 0, 1, 2, 3, and 4 are present, wherein the parameters of the system that contribute to score are respiration, coagulation, liver, cardiovascular, sinus systems, and renal functions. So sepsis categories include sepsis or severe sepsis or septic shock. In sepsis we have SOFA score of more than 2 plus infection. Severe sepsis is not applicable, where septic shock is the vasopressor requirement to maintain a mean arterial pressure more than 65. Plus serum lactate level more than 2 in the absence of hypovolemia. What is quick SOFA criteria? It refers to respiratory rate more than 22 or altermentation or systolic BP less than 100. You can refer to the definitions or the criteria of sepsis 3 in the JAMA article 2016. How to investigate febrile illness? What are the criteria? Hemoglobin with hemogram with CSR, TLC, DLC, blood sugar, liver function test, kidney function test, LDH, C-reactive protein, rapid point of care test. Then we have blood cultures, urine analysis with microscopy and culture. Then hepatic serologies, imaging such as chest X-ray, sonography, and any fluid collection for microscopy and culture. Then we have fever with sepsis. In these cases, fever with sepsis, we have to do additional testing such as serum lactate, creatine kinase, and coagulation parameters like INR and activated plasma processing time. For fever of unknown origin, like prolonged fever duration more than 3 weeks, no known immunocompromised state, uncertain diagnosis after a week of study in the hospital, then it can be either because of systemic rheumatic disease such as vasculitis, SLE, polymyalgia, or rheumatica. In 22% of cases, infection can be caused in 16% of cases, followed by malignancy, miscellaneous, and no diagnosis. What is the diagnostic approach for virus of unknown origin or fever of unknown origin? Basic investigations include CBC, malaria parasites, blood culture, microscopy, ESR, and CRP. Then in infections or anorexia, weight loss, anemia, nodes, we have we present with symptoms like cough. Then we have sputum, and if it is negative, then CT, radiologic procedures. If there is headache, then do CT or MRI, CSF studies, including cultures are required. If it is diarrhea, then stool occult blood, stool parasite, and CT abdomen. If it is neoplasm with features like anorexia, weight loss, anemia, lymphadenopathy, hypersplenism, then syndrome-based investigation is required. CT abdomen thorax will be required to look for nodes in case of as suspected neoplasm. If it is a non-infectious disorder or where oral ulcers, rash, arthritis, joint swellings are found, then do a corrosion vascular disease workup. Classify using the SLE, vasculitis, and sarcoidosis accordingly. You can refer to the etiology of classical fever of unknown origin guidelines among immunocompetent in the journal JAP 2019. How do you diagnosis of acute febrile illness? The wide array of indicators that fall under the umbrella of acute febrile illness invariably result in medical practices having to conduct various different analyses to certainly conclude an instance of acute febrile illness. Besides scrutinizing the external symptoms and medical history of the affected individual, the primary diagnostic test consists of peripheral smear examination, rapid diagnostic test, ELISA, and polymerase chain reaction. What do we see in the peripheral smear examination? In this test, the medical expert takes the blood sample from the patient and examines under the microscopy for the structure, number, and of the RBCs and WBCs and platelets. For the rapid diagnostic test, this is a sterilized needle is pricked into the patient and the drop of blood is drawn onto the antigen plate. The antigen on the plate is a protein specific to that any of the infectious diseases like malaria, dengue, jaundice, and others. The blood sample is then promptly analyzed under a lens to spot if the antibody binds to the antigen on the plate. Post this analysis, a quick lab diagnosis is confirmed whether it is a bacterial or a viral strain that causes the dengue, malaria, and other such infectious diseases, so as to enable the treatment instantly. So that's about the rapid diagnostic test and peripheral smear. What is ELISA? ELISA stands for enzyme-linked immunosolvent assay. This biochemical assay utilizes an antibody as a ligand to this, or called as a binding agent, an antibody, to discern if the specific protein called an antigen, which is found in the cell membranes of infected germs, is present in the blood sample of the patient. The ELISA test is usually used to figure out on an instance of rickettsia infections or leptospirosis. Polymerase chain reaction. This is a detailed evolution of the DNA samples into the blood of a patient, wherein they are amplified and the signal is compared to a standard DNA from a healthy individual and DNA from the causative microbial agent. In case the DNA signal from the patient blood sample correlates with that of infected microorganism, then a diagnosis of the specific case of acute febrile illness can be confirmed. So, if we see that was about the PCR, the polymerase chain reaction, if we see the blood cultures, the yield depends upon the patient selection, specimen price to antibiotic administration, the asepsis, the sets of the culture bottles, the volume taken, the number of draws, the timings between the draws, the site of sampling, the transport time, and others. The major criteria is suspect endocarditis or temperature more than 39.4 or indwelling vascular catheters. The major criteria includes temperatures, age 65 years, chills, vomiting, hypotension, neutrophils, WBCs, bands, platelets, and creatinine. What is the Shapiro score? A Shapiro score of more than or equal to 4, then there is more than 90% sensitivity alone. If its Shapiro score is more than 4 and plus procalcitonin is more than 0.25, then there is a 98% sensitivity. Blood culture provides the clinical evidence of sepsis in case of fever of unknown origin. In neurological psychiatric symptoms, then blood culture is indicated. Newer fever in critical infection, any of the clinical findings not strongly suggest an infectious disease, then blood culture is indicated. Is indicated in immunocompromised patients with underlying condition that may predispose to bloodstream infections. Then send blood cultures when clinically indicated and not as a routine. For example, pan culture for all the new admissions. So blood culture yield depends upon the specimen prior to antibiotics, asepsis, sets of blood cultures, and volume. What is the volume required? It is about 10 to 20 ml per bottle. Or optimum blood to blood ratio should be 1:5 to 1:10. For children, it is 1 to 5 ml per bottle. For neonates, it is half to 10 ml, half to 1 ml. If the volume of the blood is inadequate for the two bottles, the aerobic bottle should be inoculated first, and rest is then inoculated into the anaerobic bottle. Then the yield also depends upon the number of draws, the timing between draws, the site of samplings, and the transport time. Collect one set of blood cultures from a peripheral site and one set from each indwelling line, such as arterial line, central line, PICC, dialysis. Each set consists of one anaerobic bottle, one aerobic bottle. Cultures from all the sites should be drawn within 15 minutes. For multi-lumen catheters, obtain cultures from distal lumen whenever possible. If venification is not possible, obtain the two draws from a single lumen catheter or draws from separate lumens of catheter, but thorough asepsis in between. If patient is already on antibiotics, do not draw the blood from the lumen that has antibiotics administered to it during the previous 1 hour. Do not send the catheter tips after catheter removal for cultures. Then for the blood collection for the central venous catheter, push and pull method should be used. That's all in this session. Thank you.